So my name is Mbwide Fudibal. I'm a family nurse practitioner and I'm also Menopause Society certified, and I'm also trained in bioidentical hormone replacement. And I started the menopause clinic out of my own personal story. Moving into the transition, but not really getting the needed help. And then I just thought to myself, just like you did, like how many women are going through this and not getting the care that they need. So we're here. Yeah, so that would be me. And Deidre introduced me to this group, and we together at the same time won the Edge Grant. So part of that money, yeah, so part of that money went into securing this space and buying equipment and things like that. Um, Next slide, please. All right. So All right. So that is a light switch. I know we all know what it is, right? And I put that there to make an example between men and women. You're the only guy here. I'm sorry, we'll just have to keep picking on you. But for the guys, they just have that one light switch. You flip it, life is good, you know, we're good, right? Just hit adolescence and that's it. But look at this other side. That's what a woman's light switch looks like, right? We not only go through, I'm sorry, I said adolescence, puberty. We not only go through puberty, we go through the monthly cycles. Not only that, we get pregnant, right? Not only that, we deal with, perimenstrual symptoms. Not only that, we have to get off of, puberty, which is what menopause is. It's coming off of puberty, and that also is a process. So if anyone, tells you go and, switch off the light or turn it on, like which button are you going to touch, right? So women, we are very delicate. We are, intricate. We're wonderful. We're beautifully made. And I, as a woman, embrace all of that. And I hope you do too. Next slide, please. Talking about menopause now. So what is menopause? Menopause is the permanent cessation of period. So it's a clinical diagnosis when a woman reaches like 12 months without a period is considered menopause. So even if you had like some spotting 3 months ago or 6 months ago, and then have no period again, it's not considered menopause until you hit that 12 months without a period. And it's a natural biological process, meaning every woman born with ovaries will have to go through that. And we were talking about how people different people identify. Even if you identify as male, female, as long as you're born with ovaries, we all have to pass through that. It's our rite of passage. And the average years of menopause in the United States is 51 years old. I put this perimenopause slide up because perimenopause is also as important as menopause because it is the beginning or the transition to menopause. And that process also comes with a lot of, symptoms, a lot of variability. It's actually one of the most important stages because women will experience a lot of symptoms even in this stage. If you look at on that first side where it says the late reproductive age, the woman is still having periods, but she has like some subtle changes. Maybe the periods, it's not, instead of the normal 28 days, it could now be 25 days, or it could be, additional few days. A lot of women don't even notice that they're going through that. And then early menopause would be, okay, now we're noticing some significant difference. The period is off by maybe 7 days or even more. The late perimenopausal stage is the most important because that is when the woman starts to experience a lot of symptoms. She will go at least sometimes 2, 3, 4 months without a period, and all of a sudden a period comes, During those dry months, I call them dry months of no period, the patient will have, all the, symptoms of menopause. So the hot flashes, the night sweats, and all the unpleasant things that comes with that. And then finally, the menopause stage and the late menopause. Menopause is a natural process. It comes with a lot of symptoms. And if you look at this on this side, it lists like just a lot of symptoms that a woman experiences when going through the menopause transition. But on the other side, I listed the most common reasons that the patient comes in to ask for help. The number one on the list is the hot flashes. It is an intense heat that just comes all of a sudden, lasts for maybe a few seconds to a minute, and then it goes away. And then, now you're cold and clammy. It's like the body is confused. It doesn't know whether to feel hot or cold. It's just crazy. Vaginal dryness is another one. It is also top on the list. About 24 to 84% of women will experience vaginal dryness. Um, some of it was what Alexis was talking about, and we introduced this into the practice so that we can help women in that way. Sleep disturbance, brain fog is a big one, decreased libido, anxiety, depression, and stretch and urge incontinence. This is just like a summary. Like if we're talking about menopause, we can be here all day talking about all different aspects of menopause. But I'm condensing this in about, 10 minutes. So we're gonna just kind of get on and rush with it. Um, I specifically or intentionally put the non-hormonal treatment there because a lot of people, like when we talk about menopause, we think about hormone therapy. There are other treatments that does not require hormone, and not every woman also um, is able to take hormones, maybe for medical reasons. If they've had history of any gynecological cancer, they cannot be on hormone therapy. Or it could be, just personal choice. We just don't want to be on hormone therapy. There are a lot of new medications, and most of them are coming up now. And I just put a few up there. All of these medications have been out maybe within the last 5 years or so. The first three, Brisdale, Veyoza, Linquet, they are all for hot flashes, and they work as well as hormone therapy would for hot flashes. Ospermifene is for vaginal dryness. And then the filbanserin and Vyleesi, that is for sexual dysfunction in women. Other things that the patient can use would be vaginal moisturizers, cognitive behavioral therapy, clinical hypnosis. That satellite ganglion block I added there. It's an injection that gets injected into the spine, and it helps to control hot flashes for about 6 weeks. I'm not doing that. I'm just saying, if it's for a lifetime, I might do it, but 6 weeks, no. All right, moving on. What is it? It is the medical use of estrogen with or without progesterone to relieve hot flashes. But hot flashes is not the only reason why we use hormone therapy. It has proven to be very effective for the vaginal dryness, which is the genitourinary syndrome of menopause. It also have additional benefits. It reduces fracture. The FDA have actually approved estradiol therapy for prevention of fractures. So osteoporosis, I'm sorry. So it's not used for treatment, but it's used for prevention. And so when a patient starts on it in the perimenopausal stage into menopause, then the risk of osteoporosis decreases. Statistics have shown that about 80% of women will have osteoporosis versus 20% of men, and it's as a result of the loss of estradiol. Metabolic diseases also increases during menopause, so things like high cholesterol, diabetes increases, and the hormone therapy have shown benefit to decrease that as well. And other benefits is improved sleep, mood, and quality of life. If you're not having hot flashes at night and you're not, sweating at night, you're going to have a good night's sleep. So it has that benefit attached as well. So Recently, I don't know if you've seen that in the news that the FDA have removed the black box warning on hormone therapy just this November, November 10th, last month. So the previously when we prescribe hormone therapy, we have to tell our patients the side effects, and it could be, oh, you know what? It could cause stroke and heart attack, and it could cause breast cancer, and it could also cause dementia. A lot of women don't like, okay, just let me just let me be. I just want to have my own flashes. I don't want to have all those things. But that was as a result of a bad study that was done about 23 years ago, the Women's Health Initiative study. And that study was done not necessarily with menopause in mind. They did that study because they noticed that women, once they reach menopause age, they start having cardiovascular diseases. So stroke and heart attack and all the cardiovascular diseases. So the study was done to see the effect of hormone therapy on cardiovascular diseases. But the flaw of that study was they enrolled women that were already older. So 50, not 50 is not the older, but the to 79. And so majority of the women that were enrolled into the study were older and they were already farther along. So with or without hormone therapy, they would have developed all these diseases. But once they saw that, people were having, strokes and heart attack, they're like, oh, hormone therapy is really bad. And so for years, we did not prescribe hormone therapy at all because it's a lot of liability and no patient wants to get all these diseases from hormone therapy either. So we didn't do that, but we're so happy and excited in the menopause world that this black box warning has been removed. So we're very, very excited about that. And the warning that still remains is that of endometrial cancer. If a patient is on hormone therapy and she has a uterus, we have to have her on progesterone. If not, there's a risk for uterine cancer. So that still remains. But everything else, all the bad ones are taken off. So go ahead. We're thinking about the hot flashes now, but it's so much more than that. Later on in life, if we do nothing, osteoporosis is there on the list. The patient could develop that cardiovascular disease, metabolic diseases, so like diabetes and high cholesterol, and then the genitourinary syndrome of menopause. I remember as a brand new nurse practitioner, I was working in an urgent care at that time, and a patient came and to see me. And before she saw me, she had seen other three providers, and every time she came, she was prescribed a different type of antibiotic. It's an urgent care. And so when she came to see me, I kind of went back and I looked at all the different antibiotics that she's been on, and she's still complaining of like urinary symptoms. I'm like, this is not normal. I looked at her culture. The culture was negative. I'm like, you know what? I don't think that you have a UTI. I think I'll send you to see a urologist. Now, when I think about it, it is the genitourinary syndrome of menopause. Menopause. I was new at that time and I didn't know what it was, but I'm glad that I did not, continue on to give her antibiotics, just thinking back that was what the problem was. She was just having a lot of frequent urination because of that sensation in the urethra. Next slide, please. So what do we tell our patients? We, talk to them a lot about, self-care strategy, balanced nutrition, stress management, sleep hygiene, avoiding triggers such as alcohol, caffeine, and spicy food. A lot of patients don't know that. They just come in and they say, you know what, I noticed my hot flashes are worse when I drink alcohol. Yes, it's a trigger. Don't drink alcohol if you don't want to have hot flashes. And then supplements, we encourage that as well. All right, so we're going to talk about mental health, okay? We're going to talk about mental health. So, depressive symptoms and major depressive disorders increase during menopause. I can't tell you how many patients come in here and they probably had like history of depression when they were younger and did very well for X amount of years, 20, 25 years. And once they hit menopause, the symptoms start coming back again. And they've done studies that shows that that is true. I forgot the percentage, so I'm not gonna lie, I'm not gonna quote any numbers for you, but the incidence of depression is higher in menopause. Now, I said depressive symptoms. I want to kind of define the two. There are some times that women just feel, sad. They just feel blah, and it could be related to the menopause. Not it could be related to the menopause. It is because during menopause, there's a lot of fluctuations, perimenopause especially, fluctuation of hormones, estradiol and progesterone, and that causes all the symptoms. And to even make it confusing, some of the symptoms of menopause overlaps with that of depression. So the patient will have sleep difficulties, which is what a depressive patient experience, weight gain, appetite change, fatigue, poor concentration, all those kind of intermingle. So it is up to the provider to actually look through, tease out, and see, okay, is this menopause or is this major depressive disorder? Those who experience this in relation to menopause, once we start hormone therapy, they feel so much better. I had a patient that came in and she was like, I'm going to get fired. I can concentrate at work. My mind is all over the place. I have so much, foggy brain. The hot flashes are not letting me do anything. And she was just sitting there and just like crying the whole visit. We started her on hormone therapy. And when she came back for her follow-up appointment 6 weeks later, she was a different person, a whole different person. And she was like, oh, I feel so much better. So that is a patient that I can confidently say that her depressive symptoms are not really depression, it's related to menopause. However, if I have a patient that even though it seems like, menopause causing it, and I treat and the patient is still kind of still not quite there, then I'll refer them to you for therapy. Yes. And for management of depression I don't know if there's anyone that prescribes. You probably do prescribe, right? And you prescribe too. But the studies have shown that venlafaxine has the strongest evidence for treatment of uh, depression in menopause, and other things like cognitive behavioral therapy and other psychotherapies as well. Disorder and menopause. I would say about roughly 50% of patients that come in to see me always complain or have the complaint of loss of libido, loss of desire. Hypoactive sexual desire disorder is the persistent loss of interest for sexual activity, and that causes personal distress. And I highlighted the personal distress to say that the patient has to be distressed by it. So if it's a patient that, and when I ask this question, I always get like a look. I'm like, why is she asking that question? But if they're like, I don't have the desire, I don't feel like it, and they're talking, I'm like, okay. And are you worried by it? And a patient of mine said, actually, no, I'm fine. I don't feel the need to do anything about it because, my husband, cannot do anything, and I'm just fine without it. So we understand each other, and I don't need treatment. She is not distressed by it. She's not a patient that I would treat. So in order to make an actual diagnosis, the patient has to be distressed by it, and the symptom must persist for up to 6 months. And it's very prevalent. About 14% of patients will have that. So typically, like 1% or like 1 out of 10 patients that we see will have that. And there are different approaches to trying to come to a diagnosis, which I put up here. I want to focus, in the interest of time, I'm going to focus on the treatment. There are treatments also for that. For a long time, women didn't have anything, okay? Men had Viagra and Cialis and everything, and women were like, oh, you don't have, sexual desire? No problem. It's okay. But, um, but now we have some medications. Fulvancerin is a daily pill for the patient to take. Bremelanotide, I call it the female Viagra. It's an injection that the woman would inject 45 minutes before intercourse. That's why I call it the female Viagra. And then there's testosterone as well. Testosterone is currently not indicated for use in women in the United States. It's not been approved yet. We still use it off label, but just wanted to let you know that it's out there. All right. If you feel like this is a great gathering and the services that we provide is a needed service, give us a 5-star review. Just say you came to the open house and it was great. And next slide. And next slide. And next slide. And thank you very much. Yes, go ahead.
So the slide you did on major depressive disorder, where you were talking about fluctuations between estradiol,
Yeah, estradiol and progesterone.
is there like, I don't know, a test that kind of determines like what is the level that those hormones have to be at to really differentiate between basically indication for menopause versus major depressive disorder?
So the answer is no, because in the perimenopausal period, the hormones fluctuate a lot. During the normal reproductive years, we know what the hormones are doing at every point in time. We know when a woman is ovulating versus not. In the perimenopausal stage, the ovaries are starting to slow down, right? And so sometimes it will produce estradiol, sometimes it will not. So it's so variable. And so there's no test. The American Gynecology Society, Menopause Society, all of them don't recommend testing for hormones. So even to treat a patient, I don't necessarily have to do a hormone testing. It's all a clinical diagnosis, just going by their age, the symptoms they're experiencing and all that. For a younger patient, let me say maybe a 35, I have like a 34-year-old patient that I see that has like all like the symptoms of menopause, and she would be a good candidate for me to test because she's young, she's not up to that menopausal stage, but she's experiencing the symptoms. So I want to know what her hormones levels are looking like, and it came back that she had like a premature ovarian failure. So those are like cases where we would, but otherwise it's not recommended. We just go by symptoms. You're welcome.